Okay, so now this is the Truman Neighborhood Association meeting. It is October 25th, 2021, and we will be recording the next portion of this, which is a presentation by Dr. Alan Melnick, who is our health department, public health department official. And so thank you, Dr. Melnick. Thank you for joining us, and I will turn it over to you.
Would you, thank you. Would you like me to share my screen so I can see if I can make this work? Let's see. Tell me if you end up seeing it. Are you seeing the PowerPoint?
Yes, we can see it.
Oh, good. Okay. So let me see something here. Still see it?
No, we lost it.
Okay, let me do something different here. See if I can make it work. Does that work? Can you see it now?
Yes, we can see it now.
Okay, I moved it from one screen to another. I have two screens here and I'm playing around with them. So let me put it into slideshow mode. And I assume you can still see that because I see it right there, correct? Yeah. Great, yeah. Okay. I love the technology. So let me go ahead and get started here. So I just want to give you an update about where we are. So I'll start with the state activity. So the state rates for cases, the case rate for COVID-19, hospitalizations and deaths are all going down. That's the good news, but the numbers remain high. So this peak here was a winter peak we had last winter. This is where we were more, late summer, early fall here. And you can see we're starting to come down statewide, but we're still like at the high levels that we were in the winter. So the hospital, so these are the rate of new cases here on this graph, but hospital occupancy is similar. The hospital occupancy is consistently in Clark County been higher than 90%. And again, at rates equal to or greater that we saw in the last winter surge. And we expect that to continue through the fall, unfortunately. In Clark County, this here is the peak we had last winter. And you can see where we are more recently, similar to the state. The numbers are coming down. It's maybe hard to see this, but our current rate is at 379 per 100,000 over 14 days. At the peak, a few weeks ago, a couple months ago, we were at, or a month ago, we were at over 500. You can see 549. Last winter, the highest we got was, I believe, around 477. So we're still up in that range, but the numbers are coming down. So that's good news. Hospitalizations, here we were recently. This is the winter surge last time. Those are also coming down, but we're still seeing, 93% of hospital beds being occupied. And 15% of all beds and 30% of all the intensive care unit beds are being occupied by COVID-19 cases. So we're still seeing a lot. The deaths, these are the deaths by over time. And you can see that the deaths began to increase in late August and remain high. And the lighter part of the bar here is confirmed cases, and the blue bars is suspect cases. And I think they're described in the, I hope you can see the small print over here, but if you can't, let me know. I wish that vaccination were increasing as much as it did in the spring. You can see the vaccination rate increased in the spring. It's kind of leveled off in the summer and fall. In Clark County, of the eligible population are people 12 and older. 64% have completed a vaccination. 70% have started it, but 64% have completed it. So we've got 36% of the eligible population has not completed vaccination yet. And then when you look at the population of the entire county, which includes children who are not, under 12 who are not yet eligible, we're about 54% have completed vaccination. So that basically means we have a large population that is not vaccinated. So we're a ways away from what you might consider herd immunity. We have a large population that's still at risk for infection. The other point I'm going to make a number of points here, but one point I want to make is that the vaccinations are very effective. They're effective not only in preventing infection, they're even more effective in preventing hospitalization and death. So the case rates among the unvaccinated are considerably higher than rates among those who are fully vaccinated or partially vaccinated. So the definition of fully vaccinated are those who, it shouldn't say infected, it should say those who are more than 2 weeks after completing the vaccination series. I don't know why there's a typo in here. It's basically you're fully vaccinated if you're more than 2 weeks after completing the 2-dose series of either Pfizer or Moderna or 1 dose of Johnson & Johnson. And then partially vaccinated are those who received either only 1 dose of a 2-dose series, and those who may have completed their series but are less than 2 weeks after their last dose. And then unvaccinated, those who have not received any doses of COVID-19 vaccine. So we've been tracking the case rates by vaccination status. So the gray bar here is, the gray line here is the rate in unvaccinated people. The blue is fully vaccinated and the orange is partially vaccinated. And you can see that the rate in unvaccinated cases is 5 times higher than those who are fully vaccinated. And you might point out, why not settle for 1 dose of the Pfizer Moderna vaccine? And the reason there's a couple of reasons that these are close here. One is 1 dose of vaccine has some effectiveness, but the other point I'd make based on the definition is partially vaccinated people could have received both doses, but they may be only 13 or 11 days after the 2nd dose. So, the partially vaccinated is a large group. So, including people who are nearly fully vaccinated. So those lines go together. But the main point here is that unvaccinated folks have a much higher infection rate than people who are partially or fully vaccinated. I don't want people to rest on their laurels and just get partially vaccinated because, again, this is a large group. Some of these folks are close, but we know that you get much more robust protection and longer-term protection if you're fully vaccinated. This compares hospitalizations by vaccination status. And the rate as of late September, the rate for people who are unvaccinated for hospitalization was 13 times higher than those who are fully vaccinated. And then in terms of deaths by vaccination status, the reason we have this gray bar here is it takes some time. Death reporting is a bit delayed, and also the death certificate has to be reviewed and recorded by the State Department of Health. So this gray bar here, these dates are not, I wouldn't draw any conclusion from these dates here, but you can see where the data are complete. The death rate for unvaccinated people is 7 times higher than those who are fully vaccinated. So the vaccines are very effective in preventing infection, preventing hospitalization, and preventing death. I just wanted to give you an update on boosters. The boosters, the CDC recently expanded eligibility for vaccine boosters. So they're now available for all 3 vaccines. The reason that for the booster is even though they're effective at preventing severe illness, I've already mentioned, the data that we're continuing to monitor, we're continuing to learn about the disease. And the recent data shows that as time goes on, vaccination is less effective at preventing infection or mild illness. But even with that, most COVID-19 cases continue to be in those who are not vaccinated. The data from clinical trials show that this booster dose can increase the immune response and provide even more protection against COVID-19, including the Delta variant. The Pfizer Moderna vaccine, those the following groups here are eligible for a booster. Should be 6 months or more after completing the 2-dose series. So age, people who live in long-term care settings who are over 18. That would include, for example, people living in skilled nursing facilities, adult family homes, assisted living facilities, actually any congregate setting, including shelters or prisons as well. People who are over 18 who have underlying medical conditions, and anybody who works or live in a high-risk settings, and that includes, for example, healthcare workers, school workers, school staff. Those are all eligible for a booster. The Johnson & Johnson booster is recommended for everybody 18 and older who received the J&J vaccine 2 months or more ago. And you can actually mix and match. Those who are eligible for booster can mix and match which vaccine they receive as a booster dose. The Pfizer and J&J booster doses are the same as the first and second doses. The Moderna booster doses are 1/2 doses of the original Moderna. I'd point out that the original Moderna vaccine it's one of the 2 mRNA vaccines. It was a higher dose to begin with than the Pfizer, but the Moderna booster, all you need is 1/2 dose of the original dose. Vaccine is soon going to be available for children under 12. Right now, the one vaccine that's available for people 12 years of age and older is a Pfizer vaccine. But the FDA and the CDC advisory committee committees are meeting soon to review data and consider the Pfizer vaccine for children 5 to 11 years old. So you can see the FDA, the Food and Drug Administration Committee, is meeting on October 26th, and the CDC committee meets November 2nd and 3rd. After those decisions, the Western State Scientific Safety Review Work Group will review the data and determine if states should adopt the CDC recommendations. We believe that will happen soon after. And once that happens, the State Department of Health will authorize vaccine providers to administer the Pfizer vaccine to children who are between the ages of 5 and 11. Later this winter, the vaccine may be available for children 6 months of age and older. But that will be reviewed, and we'll need these committees to review and make recommendations on that. But coming up soon, I believe in November, we'll be adding the vaccine to 5 to 11-year-olds. I really wanted, there's been a lot of misinformation on social media about vaccine safety. So I've just included some slides to share with you about what we know about vaccine safety. And I would say that these vaccines have been the most intensely scrutiny for them of vaccines in US history. And there's several systems that are being used to monitor safety of these vaccines. One is something called Vaccine Safety Data Link, or VSD. This is a collaboration between the CDC and 9 large healthcare organizations, including Kaiser Permanente. This system, the VSD, is using electronic health record data from each site, including the kind of vaccine given to each patient, the date of the vaccination, and other vaccines given on the same day. It also uses information on medical illnesses that have been diagnosed at doctors' offices, urgent care visits, emergency room visits, and hospital stays. And actually using this data, this rich data set, the rates of adverse events that occur in people who have received a particular vaccine can be compared to the rate of adverse events that occur in a similar group of people who have not received that vaccine. So that's one system that's being used. Another system that's being used is called vSafe. And this is a smartphone, it's an app that uses text messaging and web surveys to gather information about side effects people experience after receiving a COVID-19 vaccine. And it allows the CDC to monitor safety in real time. And then the biggest database that you may have heard of, and this is going around on social media a lot, is VAERS, or the Vaccine Adverse Event Reporting System. This is a very robust, big data set that can, I would think of it as being able to, a large haystack that you can identify needles in. And And this VAERS report can help identify problems that may be related to the vaccine. I want to make it really clear, a report to VAERS does not mean that the vaccine caused an adverse event. Anybody can report. The reports can include incomplete, inaccurate, coincidental, and unverified information. Like I said, anybody can submit reports of possible adverse reactions, and all those are submitted to the VAERS website. It is not a list of verified outcomes of vaccination. The information, so the CDC and the FDA are continuously mining the VAERS database. And the information that's in there can report a potential safety problem with the vaccine. So for example, if there's, in this huge database, if there's patterns of adverse events or an unusually high number of adverse events reported after a vaccine, which are called signals, those are called signals. If those are identified, the CDC and the FDA may conduct further studies to find out if the signal actually represents an actual risk or not. So this is how a thrombosis, thrombocytopenia syndrome, or TTS, that's thrombosis or blood clots, thrombocytopenia is low platelets. This is how the risk of adverse effects involving that was found after the use of J&J vaccine. You may recall, I believe it was a late spring, there were a few reports of TTS. And these are in women who are of reproductive age between 18 and 50. There are several reports found through the VAERS database of TTS. For older women and men of all ages, this event was even more rare. And I'll tell you how rare it is. And this is a tribute to vaccine safety as well. After finding 6 reports among 6.8 million doses of J&J vaccine, the CDC and the FDA paused the use of the vaccine to do further investigation. They conducted an individual level analysis, and they looked at, on the individual level, the risks and benefits about receiving versus not receiving the J&J vaccine during the 1-month period after they were looking at this during the time when the pause was on. They were assessing the data and looking at the risks versus benefits of receiving the vaccine. What they found was, for every 1 million doses of the J&J vaccine administered to women 18 to 49, that vaccine prevented 297 hospitalizations, 56 ICU admissions, and 6 deaths related to COVID-19. That compared with 7 expected TTS cases. So the risk of TTS was far, far lower than the risk of COVID-19 that was prevented by the vaccine. The CDC then determined that the J&J vaccine's known and potential benefits far outweighed its known and potential risks, and the pause on the vaccine was lifted. But I'm pointing this out to show how this robust vaccine monitoring system really works. There's some misinformation out there on social media. I just want to point out that the number of VAERS events alone cannot be interpreted or used to reach any conclusions about the existence, severity, frequency, or rates of problems associated with the vaccine. The number of VAERS reports submitted varies each year. About 85 to 90% of these thousands of reports describe mild side effects, such as fever, arm soreness, and mild irritability. The remainder of these reports are classified as serious, which meant the event led to permanent disability, hospitalization, prolongation of a hospitalization, life-threatening illness, congenital deformity, birth defect, or death. This doesn't mean that these events were caused by the vaccine. It's just that they were listed in the reports. They're rarely caused by the vaccine. Here's some examples, and the CDC is providing regular updates on adverse events on its website. Anaphylaxis is that really horrible allergic reaction that you can have after a vaccine, and you can get shortness of breath, rash, you can lose consciousness. It's really rare. 2 to 5, you can go into shock basically. 2 to 5 people per million vaccinated can get anaphylaxis. And that is, even though this is really rare, that's why when we're giving the vaccine, you need to be monitored for 15 minutes after receiving the vaccine. This is a reaction that occurs immediately. The TTS that I already mentioned, the CDC and the FDA identified 47 reports after 15.2 million doses administered. So that's 0.0003%. And again, most cases occurred in women younger than 50 years of age. And then Guillain-Barre Syndrome, which was a where you get a paralysis. There were about, and I'm saying preliminary reports identified in bears, 233 after 15.2 million doses, 0.0015%, largely reported 2 weeks after vaccination and mostly in men 50 years of age and older. There's no identified causal link at this. That's why it says preliminary reports still being studied. And then you've heard about myocarditis in younger male adolescents and adults. 945 reports of myocarditis or pericarditis have been confirmed out of 1,638 reports. Most of them have been reported after messenger RNA COVID vaccination. That's and in the adolescents, you know, obviously under 18 it would be Pfizer, but also in young adults. That's after more than 388 million doses of the vaccine have been administered. In those cases, there have been no deaths that I'm aware of associated with those cases. They're generally mild and people recover. In terms of deaths, you may hear reports on social media. Wow, there's been close to 10,000 deaths from the vaccine. Well, first of all, I want to point out that there's 408 million doses have been administered. But the only plausible causal relationship between a vaccine and death has been associated with TTS, not other things. And there've only been 4, I shouldn't say only, any death is horrible, but there've been 4 deaths related to TTS. Far more many cases of TTS, but 4 deaths. There haven't been, I'm not aware of any deaths that have been shown causally linked to the vaccine before, besides the ones that I'm mentioning. The FDA requires providers to report any death after COVID-19 vaccination to VAERS, even if it's unclear whether the vaccine caused it. So you may have heard the last few weeks that a King County woman in her 30s recently died from TTS. She was a 4th case that I'm mentioning about in the United States. CDC has reported only 3 other confirmed cases nationally. And I want to make a point is, you know, the messaging that providers are giving out to women of reproductive age in terms of the COVID vaccine is, these deaths are incredibly rare. You may want to consider an mRNA vaccine instead of the J&J vaccine if you fit in that age group. But there's no contraindication to getting the J&J vaccine. These are really rare events. I just wanted to mention, so that's it for VAERS. I just want to mention flu vaccination. It was low last year. Flu, we didn't have much of a flu season, if any. The theory around that is a lot of the measures we're using around COVID-19 prevention, including masking and distancing, help protect against influenza as well. But flu vaccination is still the best way to prevent flu illness and hospitalization. And that can help reduce the burden on our hospitals. Be a bad season if we have flu and COVID-19 together. They're safe. Flu shots are safe and recommended to everybody 6 months of age and older. Getting vaccine, it takes 2 weeks to build up immunity from the vaccine. But you know, getting vaccinated as soon as you can now, you'll be protected throughout the season. And you can get the COVID-19 vaccine or the COVID-19 booster at the same time you get a flu vaccine. You can get one in one arm, one in the other arm, and you're good to go. So that is the recommendation. And I think that was my last slide, and I'll stop sharing so we can all be back together again. Question in the chat, looking at flu rates over the past years, do we have enough inpatient capacity to manage both COVID and flu in Clark County this winter? That's a great question. That's why I'm pleading with people to both get vaccinated for both of them, because I don't want to see us get to the point where Idaho was at, where we're implementing crisis standards of care. And we're basically having to deny people life-saving treatment because we don't have enough critical care facilities around. So it would be a bad combination. I'd also point out that RSV is circulating as well, another respiratory virus. So I'm urging people to get the flu vaccine, as well as they're not vaccinated to get the COVID-19 vaccines, and if they're eligible for a booster, to get those. Happy to answer any other questions.
If anyone has a question, raise your hand or just unmute yourself.
Are you all, I hope I didn't put you all to sleep.
No, that was interesting. Even just reading through the PowerPoint prior to it, but listening to you, that it was really good.
Sorry about that typo about fully vaccinated there. So anyway, yeah, thank you. I know I can do a monologue for a while. So.
No.
Well, I really appreciate you coming to our meeting and updating us on this. It's very, very helpful.
Well, I appreciate everything you do in terms of being a neighborhood association, supporting the community. So, and the fact that you can video this, record it for other neighborhood associations, I'm really grateful. We need to get the information out. So thank you.
Okay. Thank you, Dr. Melnick. Really appreciate it. Marilee?
Okay, I'm going to
Okay,
sign off if that's
Thank
okay.
you.
Thank you.
Thank you.
And I'm going to end the recording.